All right, lastly, cellulitis. All right, that's a good one. All right, not every patient with cellulitis needs vancomycin. All right, but how do we come up with a good regimen? How do we know what to give the patient? Here's how. Let's go through our triangle again. Okay, so most of the bacteria you're going to find in cellulitis are gram-positives. Okay, by far most of them. But how to think about what gram-positives you normally see? This is how I think about it. There's non-purulent cellulitis. Okay, so cellulitis that's a little bit red, but no clear pus drainage, no abscess. And then there's purulent cellulitis with abscesses, pus drainage. Okay, and if you think about gram-positives on a spectrum, that's kind of the first fork in the road that you want to take. For non-purulent, it's strep until proven otherwise. Okay, very rare that you see staph bacteria there. Mostly it's just strep. For purulent, you think about staph. Okay, and if you think about staph, then your next thought is right away, could this be MRSA? Okay, and there's obviously certain risk factors for MRSA, again, being in the hospital, immunocompromised, having other diseases, having contact sport. But you need to think about, as soon as you have purulent cellulitis, think staph instead of strep, and think about, could this be MRSA? Okay? So that's the first fork in the road. The second fork in the road is just to look at the patient, okay? And look, is this a mild infection? Is it a localized infection? Is this just red, a little bit pus drainage maybe, but no SIRS criteria, okay? No, not tachycardic, no, not tachypnic, not febrile, no leukocytosis. Or is this moderate? Are there some SIRS criteria? Again, this is kind of the yellow light scenario, right? Some SIRS criteria, concern for sepsis, but no real sepsis yet, no septic shock, okay? Or is it severe? Is this a patient with positive SIRS criteria, evidence of systemic infection, as well as hypotension, kind of going down the road of septic shock, okay? The treatment depends really on, is this either staph or strep, and how is the patient looking? Is it mild, moderate, or severe, okay? Don't want to forget about your gram-negatives and your anaerobes completely. You can sometimes see it in very severe cellulitis, like necrotizing fasciitis. You can see anaerobes and gram-negatives, but most of the time it's gram-positives. Okay? So how to pick your regimen for cellulitis? Here's how I do it. First, let's go to purulent. Okay? If you have purulent, you have an abscess, you have pus drainage, you always want to IND it. Okay, IND is always the right answer. All right, and then it depends on your patient what you do on top of your IND. Let's go with mild. Okay, mild, only IND. You don't even need to give this patient antibiotics. As soon as you evacuate the abscess, you're basically done. Okay, moderate. All right, so that's a situation when the patient has a fever or something else that's going on, but he's not really super toxic appearing, and you want to give this patient extra antibiotics. You don't have to take out your vancomycin right away, but you want to cover for MRSA, okay? And that's a situation when you can use MRSA coverage with oral antibiotics that I mentioned earlier. And great choices here are Bactrim, Doxy, and clindamycin. And your infectious disease attending is going to love you if you don't go for vancomycin right away, but you think about other alternatives before taking out the big gun. Well, if you have severe infection, okay, a toxic appearing patient with SIRS criteria, hypotension, etc., going down the road of organ dysfunction and septic shock, you do not want to wait. You do not want to gamble. This patient needs vancomycin in order to cover for MRSA. Okay? Then, secondly, you have your non-purulent, okay, infection. That is strep until proven otherwise. Okay? So no IND necessary. If mild, use PO antibiotics and use antibiotics that cover for strep. Okay? Penicillin is a great choice. Okay? Don't always need to go to augmentin, all right, to have a broader spectrum. Penicillin is very narrow and is normally a good choice because if it's a non-purulent infection, non-septic appearing patient, it's strep until proven otherwise. Other choices are your Keflex or clindamycin. Okay? Moderate infection, you don't change anything. You don't need to change your spectrum. You just want to change your PO to IV. Okay, but still penicillin. You can use cefaxilin now, which is the IV form, kind of similar to Keflex, and clindamycin is IV too. Okay? In severe infections, you want to think about those guys too. Okay? Anaerobes and gram-negatives, as well as your MRSA. Okay? No time to wait, no time to gamble. Patient should get vanc and SOSIN. And further workup. Okay? Further workup is most important. Do you need to get imaging to rule out necrotizing fasciitis? And if you think about necrotizing fasciitis, surgery should be called. All right? Great. All right? So this is a kind of a more differentiated view of picking your antibiotics for cellulitis. Remember, not everybody needs vanc and SOSIN, but in certain situations, that is not the wrong answer. Okay. Why not always vancomycin? Okay, that would be a great question. Well, vancomycin covers strep, it covers staph. Okay, so why not just pick vancomycin, see what happens, narrow later? Okay, here's the answer why. Vancomycin is a bacteriostatic drug. Okay, beta-lactams are bactericidal. So if you think this is a strep infection, even if the patient looks toxic, okay, you can pick beta-lactam rather than vancomycin because you're going to get a bigger effect because of the bactericidal effect rather than the bacteriostatic effect. Okay, so those are the infectious disease guidelines for soft tissue, skin and soft tissue infections, and it's pretty similar to what we went through with the antibiotic triangle of truth. Okay, again, you have the first fork in the road is a non-purulent infection and a purulent infection, and then for each one we check whether it's severe, moderate, mild, severe, moderate, and mild for both of them. Okay, if you have a non-purulent infection, you think it's strep until proven otherwise. If it's mild, go with your penicillins, go with polycephalosporin, oral, or clinda. All of them is oral. If it's moderate, change it to intravenous. No reason to change your spectrum. And if it's severe, okay, you want to rule out a necrotizing process. You want to start broad spectrum antibiotics, vanc and SOSIN. Okay, great. What about a purulent infection? Again, mild, IND is all you need. Moderate and severe, you still do IND, but you do a little bit more. For moderate, you do oral antibiotics that have MRSA coverage. Doxy, Bactrim are great choices. Okay, if you have a severe infection, you want to give IV antibiotics, and this is when you use your vancomycin. All right, perfect, great. All right, let's go to take-home points. For bacteria, remember the antibiotic triangle of truth. Gram-positives, okay, the first angle of your triangle. Use penicillins. Use cephalosporins. Okay, cephalosporins in particular, first generation covers against gram-positive. Gram-negatives, cephalosporins plus minus penicillins like Augmentin or Unicin. Each one has troublemakers. Gram-positive troublemaker is MRSA. Classic antibiotics to use: vancomycin, linezolid, and don't forget about your oral alternatives, Bactrim and Clinda. Gram-negative troublemaker, Pseudomonas, and also ESBL. Okay, think about Pseudomonas, SOSIN, Ceftas. For ESBL, think about meropenem. Okay, and don't forget about your 2As. Anaerobes are covered with clindamycin, Flagyl, but also more broad-spectrum antibiotics like Unicin and SOSIN. And atypicals, classically macrolide, tetracyclines, and also fluoroquinolones. Community-acquired pneumonia, they're gram-positive and gram-negatives. Atypicals are important to think about. Classically, no troublemakers, okay? No MRSA, no Pseudomonas, and no anaerobes. HCAP, very different picture. You have gram-positive, gram-negative, as well as troublemakers, both of them MRSA and Pseudomonas, as well as anaerobes to think about, okay? So you need to pick a broader spectrum of coverage. Meningitis, gram-positive is strep pneumo and listeria, very important in patients who are older or alcoholics. Gram-negatives, meningococci, H. influenzae, and troublemakers, MRSA and Pseudomonas, would think about if you have procedures or if a patient is immunocompromised. Your UTI, E. coli until proven otherwise. In terms of like duration of antibiotics and whether you use PO or IV, think about uncomplicated versus complicated UTI. Lastly, cellulitis, 2 big forks in the road, purulent, MRSA, non-purulent, strep, mild, moderate, and severe, and kind of helps you sorting out what antibiotic to use. Okay, so lastly, if you remember nothing else from this lecture, I want you to take away a couple of images. First, know when to gamble and know when not to gamble. You can gamble and pick a fancy, narrow spectrum antibiotic coverage for a patient that is non-septic, non-toxic appearing, and a good host for it, okay? So non-immunocompromised, doesn't have any other chronic diseases. If any of those things are not true, you want to start broad. You want to take out your vancomycin and Zosyn, okay? Next one, remember the triangle of truth, okay? It's a very easy way of remembering antibiotics and to come up with a great spectrum of antibiotics for different infections, as well as come up with a great antibiotic coverage. Okay, vancomycin has holes. Okay, doesn't cover for everything, even if the ED thinks so. Think about atypicals. Think about ESPL. Okay, and think about VRE. All right, all holes in your coverage. Do not forget about those. Think about bacteriostatic effect of vancomycin. It's not always the most potent drug, although it sounds very potent. And think about bactericidal effects of your medications like beta-lactams. Well, thank you for listening to this lecture. I hope you enjoyed it. I hope you learned something. And I hope you have fun in internal medicine, just as much fun as the residents have preparing those lectures. Feel free to contact us for any questions. Thanks a lot.